Going back to anchors, and there's a lot of marketing out there, so Dr. Bedi is going to straighten out that aspect of how our choice should be made and what anchor we should use.
Thanks, Alan, and thanks, Joe. As Alan said, my talk is to focus a little bit on, does the anchor material matter at all, and can we just use metal anchors? And I would just start out by sort of the basics of what do we really want an ideal rotator cuff anchor or shoulder anchor to do. And I made this list perhaps not exhaustive, but anchors at the end of the day need to have a good time zero pull-out strength. They have to give us versatility, as Dr. Burkhart showed earlier, with the elegant different suture patterns that become important with ripstop stitches or different constructs for different tissue quality. We want to have linkable constructs, sometimes that can be self-reinforcing, potentially retensionable. We need to have versatility. These tear patterns often can get complicated, so how do we address dog ears or margin convergent stitches that then need to incorporate into our repair? And then as we're learning, there can be some effect of knot stack abrasion, maybe more so intra-articularly, but do we have knotless and knotted options? I think the important point to emphasize here, though, is most of the time for rotator cuff tear failure that occurs early is rarely from anchor pullout. We know from Bruce Miller and Jim Carpenter and others that have published on ultrasound studies of early failure, most of the failure is at the suture tendon interface. And so as a result, probably for most of the primary cases of rotator cuff repair with reasonable bone stock, anchor material, whether it be PEEK, metal, or biocomposite, all of them are probably sufficient to get the job done. So at those early first-time time points, that may not be the rate limiter. This has been published in the literature. This is a study in 2010 which looked at this with a randomized study of 110 cuff tears, metal or biodegradable. No significant differences in terms of failure rate in multivariate and univariate analysis. The things that mattered were the other things: age, tear location, fatty atrophy of the muscle. All those things were the rate-limiting factors. Well, what about a case-controlled study? This is another one just this year in 2019, 110 patients. Again, no statistically significant differences at 4 years plus or minus 2 years follow-up for reasonably large cuff tears with a single row repair using metal or biodegradable anchors. And then this study in 2018, which looks at some of the other factors around the repair. So the idea of vented anchors or non-vented anchors or the amount of material. What these studies found was that if you did a reasonable job in accessing the marrow elements at the greater tuberosity, maybe the bone marrow-derived stem cells had slight reductions in culture, but not really any difference with regard to the material that's used. That being said, I think you have to be careful about just saying metal anchors for cuff repair, and why is that? And I think we're learning more and more, particularly as our first session showed us today, that revision surgery is becoming more and more common. We know that 50 to 80% of these tears, even in capable hands, can re-tear. And as we also are learning, we have many more new options to address those revision surgeries short of reverse shoulder arthroplasty. So what about the superior capsular reconstruction or patch augmentation or the augmented partial repair with an associated potential SCR, or the procedure that was shown earlier with the long head of the biceps tendon by Dr. Freehill? In those situations, we still need to have bone stock. We need to have real estate for those ideal anchors. And in the setting of metal anchors, we can be limited in getting an anatomic repair. It also can create some challenges for post-operative imaging where we're looking at structural integrity of our repair, secondary to blooming artifact and challenges with metal. And maybe with conversion to arthroplasty, a lot of metal anchors can create some challenges with cuff-sparing reverse shoulder arthroplasty. This is an example where it's hard to grade what's going on with that MRI in the setting of these metal anchors. Some of these can be even problematic in a different way. This is an example of a recent case I saw of somebody who had had a biceps tenodesis procedure with a metal anchor. A patient was a young patient with mechanical symptoms in the shoulder. I was concerned given the location of the anchor in a subchondral location. On the sagittal MRI, it almost looks intra-articular, and when we scope it, we can see this prominent metal anchor that's sitting here, creating abrasion against both the cuff, the interval, and the humeral head, and that required removal. Getting them out can also be hard. This is a case I borrowed from Pat Denard that shows a number of metal anchors that have been placed in now a failed rotator cuff repair. Pat elegantly shows here some techniques that he has used to try to get these out to manage in the setting of an SCR. You can see these prominent knot stacks that first have to be removed. But here you can see he has to take an anchor handle, manage to find that orifice, and then tap that into that anchor. And you can see this can leave large voids that can be challenging, as opposed to biodegradable anchors where you can even buddy anchor up against them, as has been described by Dr. Burkhart and Chris Adams and others, to get around those areas. So the removal process for metal anchors in the SCR or revision cuff repair can definitely be a concern. Does it make a difference what type of anchor you're using with regard to the architecture of the anchor? This is a recent study published by Jorge Chala and Nick Verma out of Rush just this year in 2019. As you can see here, they looked at these ingrowth anchors, and what they found was when you have coil-type anchors, you had a little bit better marrow element release, a little bit better osteogenic potential there. In general, changes in biodegradable anchors can be a little bit more of a concern. You can see more persistent peri-anchor cysts with biodegradable anchors. We know that's a concern, potentially with all suture anchors. What has been published recently in 2019 is that those that have these persistent cysts do show a higher increase in recurrent tear size and recurrence of tear in general. So we do have to worry about biocomposite materials in all suture anchors as well. So what's the summary for me in 2019? Probably pay attention to the most important factors, which are not the anchor material. Restore the footprint to restore anatomy. Remember that your supraspinatus footprint is relatively small on the greater tuberosity, and putting it back in the right place is more important than what you put it back with. Restore the cable, as Chris Ahmad and Dr. Burkhardt and others have taught us. If you don't restore that cable, you won't restore the biomechanical forces and self-reinforcement of the rotator cuff. Remember that your number of sutures are as important as your number of rows. As Scott Rodio and Tim Wright have published, a lot of this is about minimizing the forces at your tendon-suture interface, and having these types of linked constructs can help us to do that. And as this slide was shown earlier, for small retracted tears, probably everything works. But for these larger tears, you want to use every possible suture configuration with or without the ability for patch augmentation, but leave yourself bandwidth for the subsequent revision procedures, superior capsule reconstructions, or patch augmentation procedures. And in my opinion, in those cases, metal anchors can burn bridges with your subsequent revision surgery. Thank you.